Perfect.
Okay, so my name's Scott Robbie. I'm one of the corneal cataract and external diseases surgeons over at St. Thomas's. And I'm going to be talking a little bit today about the management of corneal disease. I hope that's okay with everyone. Um, we see a lot of it, especially in eye casualty. So hopefully it's relevant to your practices. And if you have any questions, you can bombard me with emails and whatnot later. And feel free to interrupt because, it's always nice if there's a bit of a back and forth between us. It means that reassures me that I'm not talking to myself, which I do occasionally, but in this context, rather not have to. Okay, so here we go. If I can get this screen to work, give me a second. Oh, golly, I'm having problems. This is a brief summary of what we'll talk about. I'm going to focus mainly on corneal inflammation of various sorts, but we can dip into other things, maybe dry eyes. There's a bit of keratoconus there if you want. So anything that's of interest. And I think most of this will be relevant to the case discussions later. Um, Before I start, I don't know how many of you have heard of a surgical sieve because that's very much a medical school thing, but has anyone heard of that?
No.
So when you're confronted with something, um, and unless it's sort of barn door pathognomonic, um, you have to have a sort of process for trying to figure out what the various differentials could be. So if you're confronted by a weird looking cornea, it's helpful to just have an acronym such as this in mind to help you sort through the possible causes. And we call that surgical sieve. And so this one, for example, the acronym is vitamin CD. And you, the vascular bit might be relevant, as we'll see, because a patient might have vasculitis that might manifest in the cornea, or have a systemic vasculitis that could manifest that way. They might have an infective cause for that problem, very often, in fact. They might have had trauma in the past, usually, rather than acutely. And they might have an autoimmune disorder. That's not uncommon. They might have metabolic problems. So they might have diabetes. Diabetes does affect the cornea, so it can make the nerves not function correctly in the cornea. And we know that corneas have huge density of nerve fibers in them. So if the patient has peripheral neuropathy due to their diabetes, uncontrolled hyperglycemia and whatnot over their lifetime, then that can render the cornea inflamed and dysfunctional and the nerves not functioning correctly. And then we can have iatrogenic problems, hopefully not too commonly, but they do happen. And you will see things in your practice which may account for where a doctor's been at work and the results are things like, you might see LASIK flaps that have gone wrong, things like that. Neoplasm, again, something you always need to have in mind. So particularly if something's unilateral, we think, you tend to just have neoplasm in the back of your mind a bit. So things like if you've got symblepharon shortening in one eye of the fornix in one eye, not both eyes, then you start to think, could this be not inflammatory but neoplastic? And then there may be congenital problems. So sometimes you get maybe congenital measles was one hopefully historical problem that manifested as interstitial keratitis, early on. You still see that in patients very occasionally, some clinics. And then it could be degenerative. And I think, obviously, Alzheimer's, as far as we know, doesn't manifest in the cornea, but things like fuchs endothelial dystrophy, you could class as degenerative. So there you go. I hope that's fairly helpful because you'll probably forget everything else I say in this talk, but having a structured approach to causes for things is useful. So we're going to talk a bit about inflammatory corneal disease. And corneas are not hugely complicated things, at least maybe because we just don't do enough research into them, but compared with the retina, which has whatever 10 or 11 layers to it, and all sorts of wiring interconnecting. Cornea is basically a skin on top, which is the epithelium, and that sits on a sort of modified basement membrane. We call that Bowman's. And then there's the stroma, which is largely collagen and water. And then beyond that, we have the Descemet's membrane and endothelium. And all of these structures, to a greater or lesser degree, can become inflamed. When the stroma becomes inflamed, and it's only the stroma, that's called, as a general rule, interstitial keratitis. And then we can get epithelial and stromal inflammation. And that might have multiple causes. And if you go through your surgical sieve, then you can attribute various causes to whatever's confronting you. Very often it's infectious, but we do see occasional corneal melts, which are autoimmune in nature. We might see persistent defects in the epithelium with some associated stromal inflammation that's associated with allergic eye disease, for example. That's quite common. And we might see stem cell failures secondary to inflammation, and rarely, fortunately, that's a feature of mucous membrane pemphigoid and other conditions such as Stevens-Johnson syndrome. Stevens-Johnson's pretty rare, but it's usually the result of drug reaction. Usually there's a clear history of a drug reaction, and essentially the patient comes out in a rash, and then the skin becomes inflamed, and essentially they have what is it, a generalized burn picture, and the eyes become involved due to conjunctival inflammation and some blepharon formation, and if it's uncontrolled, ultimately that can affect the stem cell populations. But as I say, that's pretty rare, and usually we step in quite late in the process, so the medics have admitted them and started treatment, and then we step in and manage the eye inflammation. And then, of course, there's endotheliitis, which is where the endothelium itself is inflamed. And usually, if we're seeing that, we're thinking of things like herpes simplex virus. CMV is also recognized to be a cause. And it's not always the case that we confirm the diagnosis in these sorts of cases. We tend to treat fairly empirically, but you can draw samples off the aqueous and send those off for PCR if you are not sure what you're looking at. So stromal inflammation. This is what you might see from time to time. This is obviously chronic inflammation. If there's no epithelial breakdown, what you'll see is lots of vessels infiltrating the stroma of the cornea and associated scarring. I suppose the biggest cause of this in the world is probably chlamydia trachomatis, so trachoma, which is due to poor hygiene in developing countries. And you will from time to time, if you work in an area which has a high immigrant population, you might see patients coming in who've lived in developing countries in childhood, and they may have these sorts of signs. But I'm just going to move this around a bit. Sorry, just a sec. So what is interstitial keratitis? Well, it's non-ulcerative inflammation of the corneal stroma without significant endothelial or epithelial involvement, as I've said. Synonymous with non-ulcerative keratitis, syphilitic keratitis. We don't see much of that now. And avascular interstitial keratitis. And usually we're in the business of managing the underlying cause of something like this. This boat has clearly sailed. This cornea's inflammation is probably burnt out. It's not particularly active. It's always going to be primed for inflammation for it to become inflamed. But we're usually trying to rehabilitate vision in this situation. But you might, if it looked active, manage it with topical steroid. Bear with me a second. I'm just going to move things around a bit. So this can be infectious or immune, or both. Diffuse, focal, multifocal. So you might see just one area here affected, And that's not uncommon if someone's had a previous episode or episodes of herpes simplex keratitis, for example. Could affect any layer of the stroma. You might see it superficially or deep. And it might be vascularized or it might not. Okay, so you can see these sort of signs independently of one another. And here's a huge list of possible causes of something like interstitial keratitis. This is an incomplete list, but various bacteria can cause it. Some mycobacteria, TB. And of course, the big cause for us, we see most often is herpes simplex keratitis. And there are various other causes that you might want to exclude once they land up in clinic with us. We might do a range of blood tests to try and exclude other possible causes if we're not sure of what's going on. Some of these can be active, okay? And so something like acanthamoeba is always worth bearing in mind, particularly in a contact lens wearer. So the other thing that we occasionally, this is much rarer, but what you see from time to time is inflammation and ulceration due to non-infective causes, so autoimmune inflammation. And as a general rule, we're interested in excluding and treating infection before we make a diagnosis of an autoimmune melt. That's much more common infection. And so we will undertake corneal scrapes to exclude it and then try and go about understanding what the possible cause could be. If a patient has a history of rheumatoid arthritis, this is almost always evident from the history. And it doesn't have to be active systemic disease. So even though the joints may be quiet and everything's controlled from a systemic point of view, we always have to bear in mind that for some reason, the cornea is still susceptible to inflammation in these patients. And so you can see sight-threatening corneal melts in rheumatoid arthritis patients who've not really had problems with their joints for a long time. And then there are various other autoimmune conditions. I don't want to go into those in too much detail. The main thing is probably to recognize that rheumatoid arthritis is a big cause of those that are out there. And then there are these rarer causes of autoimmune conditions that affect various mucosa. Moorings is quite rare, and it's largely a diagnosis of exclusion. Obviously, we will see that the epithelium will have broken down in areas affected here. And it's just worth bearing in mind causes of persistent epithelial defects. So things like, as I mentioned, Stevens-Johnson syndrome, mucous membrane pemphigoid, and atopic eye disease, which are all usually already diagnosed, or we'd be aware of those. But you can get surface failure secondary to these conditions, and any surface failure can may be associated with inflammation, and if not infection, it can certainly cause a melt of the stroma if not managed properly. As a general rule, we're not in the business of throwing huge amounts of systemic immunosuppression at patients. We're fortunate that the eye is readily accessible to topical therapy, and we will usually try high-potency topical steroids and topical cyclosporin before considering alternatives. Tetracyclines such as doxycycline and minocycline orally can be helpful in controlling melts because they have an effect on what we call matrix metalloproteases in the cornea, and that blocking the action of those will limit the risk of collagen breaking down and an accelerated melt. So quite frequently we'll put patients on those if we suspect that they might have something like this. And then if cases are particularly severe and there's poor prognosis without rapid response to the topical treatment, then we will certainly consider high-dose oral or IV steroids, pulsed methylprednisolone. And then if you're considering that, then you need to usually consider what we call steroid-sparing agents, which are much safer in the long term to control the disease. So as I say, we exclude infection as the main thing you really want to think about. And then we screen for these various possible causes. and then work them up for systemic immunosuppression at the same time. So you've got a whole package of measures in place that allow you to manage the disease appropriately. And these are a few examples. So you see here, this is sort of fairly burnt out disease. This is Moran's disease. It can be quite debilitating for the patients, clearly, and often, if uncontrolled, it can lead to total blindness. Here's an example of rheumatoid melt down here. And you can see that there's sort of guttering here. So there will be a loss of epithelium in this area. And there's no sort of clear cornea between the affected area of melt and ulceration and the limbus, which is different to things like infective keratitis usually, where you will have an area of clear cornea separating the area of ulceration from the limbus, and things like marginal keratitis too. And you can see if left to its own devices, this cornea can melt through, and then the iris ends up plugging the defect. So it's always worth looking under the lid if you've got a patient with problems like this, because I've seen patients who've had bilateral disease, but if you hadn't looked under, so that one eye might look very obvious like this, and then you look at the other eye and you think, oh, that one's fine at least. But if you look under the lid, then you start to notice that, oh, okay, there's a problem there as well. So don't forget to look under the lids. Okay, this is a summary of the systemic therapy treatment step ladder. Various poisons. Some of these, what's kind of changed the game a little bit is some of the monoclonal antibodies that are much more, not necessarily effective, but do have a better side effect profile than some of these other drugs. And so this is changing the game a bit. And what's more, some of them are coming off patent, and we're able to prescribe them more easily than we used to. Persistent epithelial defects. So we will see this from time to time. I guess in your practices, you might not necessarily. You're going to be more at the sharp end in the acute phase of these things. But it is worth bearing in mind that some of these eyes are susceptible to epithelial breakdown that just drags on. And usually it's because of uncontrolled inflammation or uncontrolled infection, in fact. So dry eye can cause persistent epithelial defect. When I say iatrogenic toxicity, I mean things like some eye drops that we prescribe, particularly those containing benzalkonium chloride, trauma, neurotrophic ulceration, and those with diabetes particularly, patients who've had infections, and then there's sort of chronic inflammation that's not permitting the ulcer to heal, thinking particularly of HSV there. And then there are other ocular surface inflammatory diseases, atopy, so allergic eye disease being one of the key ones that could cause epithelial breakdown, and if not managed appropriately, a persistent ulcer that then causes more problems for the patient. So this is toxicity in early ocular cicatricial pemphigoid. So this earlier one, this is a mucus plaque in a patient with Sjogren's. This is neurotrophic cornea post-surgery, probably managed with amnion. And this is infection, so it's most likely candidal, and it's just sort of sitting there and not permitting this ulcer to heal. And you can see the edges are slightly rolled, so it's not the Bowman's layer, the basement membrane for this epithelium has been completely disrupted, and there's no way it's going to heal over this without some assistance. So with these, we're in the business of trying to control the inflammation, whilst at the same time excluding infection. One of the things that you need to think a little bit about, particularly if you're prescribing, is that steroids can mask the effects, the signs associated with infection. And I still have to sort of hammer that into the juniors who are seeing these sorts of cases in eye casualty, that for patients on steroids and they've got a corneal ulcer, you're going to miss a lot of the signs that would normally be present. And so the juniors might sort of attribute an ulcer to non-infective causes when in fact they do have an infection. So any patient who's on steroids and has a corneal ulcer ought to be scraped to exclude infection. But having said that, if there's inflammation about and you've got an ulcer that really isn't healing, then you need to think about controlling it. And if a patient needs topical steroids, very often they'll benefit from a steroid-sparing agent, so topical cyclosporin, which there are a couple of suppliers now, not just Icavis. That's quite helpful for controlling atopic disease in any case, and things like rosacea, which is another big cause of this sort of thing. So just to run through that step ladder again, exclude infection, stimulate epithelialization. So we're going to prescribe lubricants, maybe consider therapeutic contact lenses, autologous or allogeneic serum drops. It's very rare that we prescribe autologous serum drops now. It's the rate limiting step is that the patient has to give blood, and that takes a lot of time. They have to book into their local blood donation center. It just seems to take forever. And actually, a lot of these patients are quite elderly. They've got various other health issues, and they're not necessarily suitable candidates for donating blood for generating serum drops. So most of the time, we ask NHSBT to supply allogeneic serum drops. And more recently, we've started to, the pharmacy at St Thomas's will source insulin drops for us. And those are quite helpful, particularly in the diabetics, for encouraging healing of epithelial defects. Botox-induced ptosis or a central tarsorrhaphy can also be helpful. Try and increase the coverage of tears on the surface. We might consider things like refining lamella transplants or amnion more often to give a new surface and protect the surface whilst it's healing. And then more extreme cases, you might find yourself undertaking surface reconstruction surgery. But it's usually the simple things that are effective. Marginal keratitis, I'm sure you guys see this from time to time. So it's fairly typical. You'll see some staining here, usually a bit of uptake of fluorescein. You can see there's sort of a slight pannus formation, some extension of superficial vessels into this area. But this area usually will have sort of, there won't be any thinning or ulceration in this area, like I mentioned with the autoimmune melts. You just have this sort of area of infiltrate and epithelial breakdown. Very often you'll see meibomian gland dysfunction associated with this as well. And all of that is very suggestive of marginal keratitis. It's usually parallel to the limbus in this configuration, maybe down here. You tend not to see them up here very much. And all of that is going to respond to, of course, topical antibiotics, topical steroid, and lid hygiene measures. And if it keeps coming back, then we start to think about, well, what tends to happen is that the patient lands up in eye casualty after a few episodes, and then they get shunted over to the corneal service. And at that point, we might start to tease apart the history a bit more, and it's often clear that there's a history of rosacea or eczema that might account for this sort of thing. And if they're having multiple episodes, then we will start them on a topical long-term steroid-sparing agent, which is a lot safer than them being managed on topical steroids indefinitely, that's for sure. There are a couple of options there, by the way. So we don't have a lot of drugs at our disposal from a topical point of view beyond steroids and antibiotics. But the topical cyclosporin is very helpful, tends to sting a bit when patients put it in. That's usually once a day. But the tacrolimus ointment, which is widely prescribed for eczema and things like rosacea, it's quite helpful. So although it's off license, we don't advise that necessarily patients put it directly in the eye, although they can do. We get them to put a little bit on the tip of their finger, and then they just run it along the lid margin. If a bit goes in the eye, that's usually a good thing. And you can titrate that a bit as well. So they might not need to put it in every day. They might just need to apply it to the lid margins once a week or a couple of times a week. And so patients are very happy to do that, as long as they don't get the burning symptoms that comes with the ointment. The ointment tends to trigger certain pain pathways. It's a bit like chili, the way the drug acts on these pain pathways. So they tend to get a slight burning effect. Most patients, it's not a problem, but some of them it definitely is. Okay. So microbial keratitis. I don't particularly want to bore you with this because I'm hoping that everybody's very familiar with the management of this stuff. This is a fairly typical case of stuff that might land, the sort of thing that might land in eye casualty and ultimately in my clinic. So it's an 18-year-old woman, contact lens wearer, fell asleep with her contact lens in, woke up with pain and redness in the eye, and this is the result. Okay, so you can see here, there's a lot of inflammation, there's a hypopion, there's an ulcer, and with slothy looking tissue. And this would be fairly typical of a Pseudomonas ulcer, which is probably the most common cause of contact lens associated keratitis. And no doubt, if you were to look into this anterior chamber, you would see that there's maybe lots of cells, some fibrin. Even the iris vessels might be a bit dilated. You can sort of make that out here, actually. So all in all, a very inflamed eye. This obviously comes to eye casualty. If you see it, don't dawdle. Just send it to us. We'll see them. This is obviously a much smaller ulcer, and again, this is probably much more common. So these one sort of 1 millimeter corneal ulcers with a bit of stromal infiltrate and contact lens wearer. We're not blasé about these, but most of them will respond to topical antibiotics, such as moxifloxacin. It has to be broad spectrum. Yes, we want to see these in eye casualty as well. Don't try and manage them at home with chloramphenicol drops because Pseudomonas is resistant to chloramphenicol. So you may end up prescribing an antibiotic or advising the patient to get hold of an antibiotic from the chemist that is not going to work for them, and then they can end up in a much worse situation pretty quickly. So there's an argument for saying you don't necessarily need to scrape these. I think because we've had some misses and it's difficult to be sure that the patient is seen in eye casualty by someone with the necessary experience. You know, if the trainees turn around, we've sort of suggested that they all have scrapes now, these sorts of eyes. But as I say, most of them will respond quickly to a course of moxifloxacin drops, which we would normally give hourly, day and night, ideally for 2 days, and then hourly by day for a further 5 days or 3 days, I think. So all of these diagnoses are fairly provisional. Okay, so we like to review them at 2 days, and we have to always think about why did they get the ulcer. So if they wear a contact lens, that is a risk factor for corneal ulceration and infection. But there may be other factors in play. It's worth thinking about those. So things like if the lids are not closing properly, are there lashes on the cornea? Do they have a history of diabetes, maybe neurotrophic keratopathy, this sort of thing. So as I said, Pseudomonas species account for up to a quarter of all microbial keratitis cases and 70% of contact lens associated cases. But it's worth bearing in mind that most of these data sets indicate that there are other organisms involved in about 10% of cases. And why does this matter? Well, just remembering that chloramphenicol is not effective against Pseudomonas. If there are multiple organisms involved, then you might find that your treatment's not working. And then we start to go down this pathway or initially start investigate. So if we suspect things like fungi or acanthamoeba, then we will undertake confocal microscopy. At the moment, that gets outsourced to Moorfields because we don't see enough cases to justify confocal at St Thomas's, although there is an argument for it. And then we may rescrape after 48 hours if we think things have got a whole lot worse. But frequently you will see a bit of worsening after starting treatment because you're killing all the bugs, and then you get a bit of an inflammatory response to dead bugs. So, obviously the idea is we want to establish a cause, ensure there's an appropriate response to the treatment, and manage appropriately. In exceptional circumstances, we may find ourselves, if there's perforation, doing a tectonic, hopefully a lamellar transplant rather than a penetrating keratoplasty. But I don't want to bore you with that too much. And as I said, generally as a rule, we will prescribe monotherapy. It's much simpler for the patients. But there's always a chance that they've got an organism that isn't responsive to something like moxifloxacin. Bearing in mind that Pseudomonas is covered by moxifloxacin, but some antibiotics are better than others. For certain organisms, and so maybe gentamicin might be a better option for some patients. And so if that's the case, then we'll prescribe gentamicin and cefuroxime drops for the gram positives. But as I say, most will be covered by the quinolones.
Mr. Robbie, can I interrupt for a moment?
Mm-hmm.
We're approaching 35 minutes past.
Okay.
I wonder if we would be able to answer some questions in about 5 minutes.
Yep, absolutely.
Thank you.
Yeah, so hourly for 3 days after that first initial 48 hours. Most units will adopt that strategy. Okay. If you think an elderly patient's not going to be able to put the drops in, then obviously there's a good case for us admitting them, and frequently we usually will if that's a problem. Okay, right. So again, another bacterial ulcer. These are fairly, not a lot of things give this appearance. So if you're seeing that, you can be fairly sure that they've got an infection. Fungi can be difficult to diagnose on the appearance, and you will see fungal infections in some contact lens associated keratitis patients. So some contact lens wearers have developed fusarium infections, for example. You always have to have it in the back of your mind that you could be dealing with more than one organism or even an isolated fungal infection. Typically, fungi are supposed to have sort of raised plaques. They do have sort of atypical appearance, and I think we'll all agree that this is fairly atypical compared with what I've shown previously. This sort of scalloped margin here, serrated margin, lots of sort of satellite lesions, plaques on the endothelium. These are all sort of funny little signs that make us think that maybe this is not your average bacterial keratitis. And really the only way to diagnose it is to do confocal and combine that with corneal scrape afterwards. And hopefully your unit is able to send the sample off and get a positive PCR result fairly quickly. One thing it's worth knowing about is that steroids and fungi are bad news together. So if a patient's on steroids, we stop that because the steroid really does let the fungus run riot. You've got no immune response to the fungus, and it can go crazy pretty quickly. HSV. So I'm sure you guys see a fair amount of this from out and about. Very often it's clinical, and when it looks like this, it's very difficult to argue with that diagnosis. It's almost certainly going to be HSV. It's quite a large geographic ulcer. It's very rare that you see HSV cause long-term problems for the patient unless they sort of end up with sort of chronic herpes simplex keratitis and vascularization and nummular keratitis, all this sort of scarring, long chronic scarring responses in the cornea. More often, when things really patients get into trouble is when it's diagnosed, when something like acanthamoeba keratitis is diagnosed as HSV. And I'm not accusing you guys of doing it, but it will happen in eye casualty from time to time. When it does, it is a disaster because the acanthamoeba, the patient may come back to eye casualty a couple of times. Once that diagnosis of HSV keratitis is in the notes, it's very difficult to shift people's approach to it. And then people try all sorts of things. They'll start, when it doesn't respond to the usual treatment, they'll put them on steroids, and then acanthamoeba tends to do much worse if steroid drops have been started before the anti-acanthamoeba drops. So just be careful of making this diagnosis in a contact lens wearer. Just because you've got positive tests, you can get false positives, so it doesn't necessarily mean HSV is the cause. You don't need to kick off with steroids straight off the bat. Consider your differentials. And resistance is pretty unusual, so that shouldn't be top of your list of causes for what you think might be HSK that is unresponsive. This is sort of vernal plaque in atopic keratoconjunctivitis. This is sort of mucus plaques in zoster, which can be difficult to differentiate between from herpes simplex keratitis, but generally you get these sort of stellate appearances with zoster, and the epithelium is a bit more heaped, rather than as opposed to the sort of classic dendritic ulcers you get with HSV. And then here we've got a sort of corneal epithelial basement membrane dystrophy and sort of ring infiltrate with acanthamoeba. So if it's that, then difficult to argue with the diagnosis, but always be careful on a contact lens wearer. Right. Shall we? I don't particularly want to spend a lot of time on herpes simplex keratitis. Maybe we can skip some of this.
While we're flicking through, there was one question in the chat based on cyclosporin, and it said that if there are other options other than Icurvis, do you have a first choice, and which is the most cost-effective option?
Oh, that's a good question. Give me 2 seconds. I'll come back to you. Literally.
Oh, goodness. If anyone else has any questions, then please feel free to either type it in the chat, or you can obviously you're currently all on mute, so please unmute yourself.
So this is what one of the reps gave to me. They work for, what's the company? Oh, got it. Can't see it now. Anyway, this one's called Sequa. So it's coming off sort of patent topical cyclosporin. I think that's why we're seeing more options. And so this is a bit cheaper than the Icurvis, at least at the moment. Generally, competition tends to stimulate a reduction in cost. So I think we're getting this in our pharmacy now. I don't intend this as an advertisement for any of them, but there are increasingly options such as this. So that's still going to have a cost implication over the course of treatment. So whether it shifts my approach to some of these cases, some of these patients, I will just prescribe topical tacrolimus and the topical cyclosporin, and I'll say to them, try one or the other, and whichever you favor, you can carry on with. But I'll usually say try the tacrolimus first, because if they get along with that, even though it's off license, they can titrate the treatment a bit, and it's a lot cheaper in the long run, and I don't necessarily have to see them every year to rubber stamp a prescription of something like that. So yes, but you choose whichever way you wish to go on that one. Right, I think I'm repeating myself with some of this stuff, so we're going to just rattle through this.
Okay.
Okay. So some of this winds up in clinics. So the sort of nummular keratitis, this sort of stromal involvement following a long vanished herpes simplex infection. And that can cause problems. And sometimes it's possible to misdiagnose this as well. So I'm thinking one patient in particular who came in with contact lens associated keratitis, which was assumed to be bacterial. And it just took ages to shift. And this isn't the eye, but he got sort of vascularization in this area and recurrent epithelial breakdown. And it was only after thinking, oh, this is really odd. Why is it doing this? This is not like a bacterial keratitis at all, although they can get vascularization. And then we swabbed him, and it turned out he had herpes simplex keratitis as well. So you do see sort of, just bear in mind the polymicrobiality of some of these things. Okay, I don't particularly want to. Epithelial disease. So this is fairly typical of just sort of the epithelium being involved. Then we'll just throw Vergan ointment at them, and it gets better pretty quickly. If there's any stromal involvement, then the evidence suggests that they should be on an oral treatment, oral acyclovir. If it's epithelial disease, most of the time it will heal within a week or two. You might, if it's slow healing, you might want to consider any neurotrophy or the need for managing inflammation with some steroid. Rarely, you might see acyclovir resistance. And then there are these herpes eye disease studies, which basically indicated a role for oral acyclovir in halving the number of recurrences over the course of a year, or the duration of the study. So in those patients, you've got multiple episodes of herpes simplex keratitis. And bearing in mind, every time they get seen, they have an episode, the cornea just gets a bit more scarred, it gets a bit more irregular. Then I will often think, at least give them the option of going on oral acyclovir, which is 400 milligrams twice daily, as a sort of way of reducing the risk of recurrence. But it only has that effect whilst they're on it. And then there's this business of resistance, where the patient's taking the drug and so forth, and always consider the acanthamoeba keratitis in those patients who are at risk of it. Okay, don't want to go on about that. Acanthamoeba keratitis, always important to have this in the back of your mind, okay, in a contact lens wearer. So the signs may be minimal early on, and we still see occasional patients coming through who have had symptoms of sort of funny little symptoms of dry eye, maybe a bit of redness, maybe a bit of irritation or grittiness in the eye. And it might have started out just with a little bit of haziness in the cornea. But it drags and drags, and then maybe they're seeing an eye casualty, maybe they're not managed appropriately. I think I'm not doing my eye casualty down, they do a great job. But some of these slip through the net, and it can be a total disaster, you know. I'm thinking of one I've got on my books at the moment, had a really difficult time managing her. She was pregnant when she developed symptoms. She gave birth a couple of months after presenting, and she'd been on topical PHMB to manage this after we made the diagnosis fairly early after she presented. And then she had confocal, and it showed lots of cysts really deep into the cornea. But the eye was relatively quiet, and then she gave birth, and the eye just went crazy. I mean, it started to look like this very quickly, and not long afterwards like this, but mainly sort of in the superior cornea. And I could not control this inflammation for love nor money. And then I did an early lamella, as deep as I dared go, to try and debulk all the cysts from the cornea. She was on immunosuppression and everything. And, you know, ultimately, you know, we haven't completely lost the battle, but she's got an anterior staphyloma. She's got surface failure now. And that's after at least three lamella grafts we did. And I went deeper and deeper in the cornea every time. And for the first two, they just separated. It was very traumatic. And she's a young woman. So always have this in your mind. Could this be acanthamoeba? Okay, it's just a funny red eye in a contact lens wearer. All of that needs to go to eye casualty, and they should be thinking about it too.
Is that typical that pregnancy can sort of cause these sorts of things, these niggly, lingering?
Well, I think when you're pregnant, your immune system's in a bit of a funny state. You're kind of immunosuppressed in a weird way, because your body's sort of learning to tolerate the fetus, the developing fetus. I'm speculating because I haven't sort of done a deep dive on the evidence base for it, but it was really interesting that once she gave birth, then she had real problems with inflammation in the cornea. And up until that point, the cysts were just sort of sitting there, fairly dormant, I would have thought. Yeah, it was really striking.
Thank you.
Okay, so that's that one. So as with any kind of infective cause, have an idea why have they got an infection? Okay, is it just because they're wearing contact lens, or is their lens hygiene poor? Are they on any medications? Contact with vegetable matter, things like that, particularly in developing countries. Any pre-existing ocular surface disease? Do they have lots of blepharitis? Could that have predisposed them to an infection? This sort of thing. Okay. And then there are other things like diabetes, obviously, alcohol dependence, previous surgery, recurrent disease. Always have a we think. What was the underlying cause for this? Okay, I'm hammering that home, aren't I? Okay. Do we dip into keratoconus? Because I think that's one of the cases, isn't it? Is there time for that, Bavina?
We're running tight on time. We can discuss it, or we can discuss it as part of the case. What would be more efficient for
Well, I'll tell you
you?
what, I think I've only got 2 or 3 slides on this.
Okay, perfect. I'll
Okay.
let you
So we'll
carry
just do
on.
this because I think it features in the cases, and then at least you're not going in completely ignorant on the subject. So this is a 21-year-old man with suspected keratoconus. This is fairly typical of the sort of refraction we might see in a referral. The optometrist will have said, "Oh, this is funny, the sills increased over the last few years," and they might have the scissor reflex on a retinoscopy. That is fairly standard. Um, it's nice to have a bit more information. Obviously, if you do have previous refractions, we'd like to see them because it may give us the ammunition we need to pull the trigger on a cross-linking procedure. Um, Always worth noting if they're eye rubbers, do they have ocular allergy, things like that. Um, when we do topography, very often we'll just see this is sagittal curvature. This is fairly pathognomonic. But occasionally you might see that this is caused by an epithelial change and not actually by keratoconus. But for the most part, this is what it will look like if a patient has keratoconus to a greater or lesser degree. And this is a bilateral disease. So even though we won't see it in the left eye in this case, if we were to look at the various indices, you might see that there are posterior changes early on that indicate that this eye is going the same way unless we watch it and treat it accordingly. This is should we cross-link is usually the question that we pose ourselves in clinic and we put to the patient. Generally, we're looking for sort of 1 diopter changes in K1 or K2. Kmax is less reliable, particularly in more advanced disease. But if there is, so for that reason, if there is advanced disease, we're looking for bigger changes because it's the scans tend to be much more variable. What's more important in some ways is what is the age of the patient and what are the various risk factors going on. So if this patient is young, less than 18, or for that matter in their early 20s, we're going to watch them really closely if we're not sure that there's been progression or not. And if it's sort of borderline, then very often I will give them the option because that's what I feel I would do if it was, my son or daughter or my relative. I would say, look, you're young, very likely you're going to progress over the next few years. If there's even a hint of a sniff of keratoconus having progressed in the last few years, we're going to cross-link them. Okay. But you can see progression at any age, and some of these patients will land up in clinic in their 50s, and usually they're atopes and they're still rubbing their eyes and whatnot, and those can progress too. More rarely, we might see patients that are referred in who've got sort of funny Ks prior to cataract surgery and things, and it turns out they had keratoconus that progressed in their 20s and 30s, and then nobody really noticed until they got around to having cataract surgery in their 60s or 70s. If they are keratoconic, then very often we'll want to do those cataracts in the corneal service, just because I think some of the other surgeons are less adept at using the corneal topography to inform their lens power choices. And the corneas themselves tend to be a bit leaky. So you make a wound in a keratoconic eye, the wounds tend to be a bit more leaky. So we'll have a lower threshold for putting sutures in the wounds and things when we're doing cataract surgery on those patients. Okay. if a patient has actively inflamed ocular surface disease, then obviously we want to control that before subjecting them to a cross-linking procedure. There's a sort of arbitrary cutoff for the minimum corneal thickness. I wouldn't let that drive a referral or a decision to cross-link. We'll treat thinner corneas, and actually the evidence for cross-linking damaging the endothelium, for example, is fairly limited. So you can go subject pretty thin corneas with various modifications to the protocols if you have to. But the more data, the better, generally. Okay, so if you have data that you can supply us with in your referral, that's really good. Sometimes the referrals are not dated, so that's helpful. If the referral's dated, then we can sort of that helps us get a feel for progression. Again, historical refractions. Recently we've seen more of these cases going through the independent providers. So Czech, for example, Czech don't have. So if you go to, where is it? Can't remember where they're based. It'll come to me. Anyway, so because they don't have the topography, they can't necessarily confirm the diagnosis or, for that matter, follow the patient. So it just delays things if the patients go through the independent providers on this very often. If they're a contact lens wearer, then you can ask them to keep their lenses out before we see them. That's asking a lot of some of these patients. They're very dependent on their contact lenses. So, that's not written in stone. And if they're younger, we want to see them earlier because they're more likely to progress. Okay. Keratoconus and cataract, I've already said a bit about. There's a higher risk of refractive surprise in these eyes, okay, for obvious reasons. So we generally will do these cataracts in the corneal service, not least because we want to establish that the cornea is stable before we do any cataract surgery on them. Okay, I'm going to pause there. Allergic eye disease for another time. I'm sure you've heard that all before. Anyway, any questions? And if not, Pavina is going to direct us to do some cases, I think.
I am. I'm also going to just quickly stop the recording.